Thank you, Bwana Elo Mapelu, our ABO chairman. I think I'm clear enough and audible enough.
Yes, you can hear you.
Okay. Sawa. Thank you. So, thank you for this opportunity. Firstly, I would like to welcome everybody to our World CML Day 2022. Most of us here have celebrated a few of those, and it's a privilege to walk this journey. It's a privilege to be with you guys here in this meeting today. So without further ado, I'd like to share briefly about my story and how it relates to this year's theme of celebrating the positive impact of access program for CML patients in Kenya. So I think we got that theme. I can just repeat for those who did not get it clearly. This year's theme, we are celebrating the positive impact of access programs for CML patients in Kenya. I am a CML patient, and I am a survivor. I am a survivor for almost 9 years. I hit 9 years in August. I was diagnosed on 13th of August, 2013. So this is like my 9th year on treatment and on survivorship. And a brief history of how I was diagnosed is back in 2011, I used to have these symptoms that I didn't know of. I used to play hockey back in high school, and I thought I used to feel a lot of pain in my limbs, in my legs, and I was always tired. So I thought probably it is just part of, the side effects of maybe playing a lot of game time in high school. So from 2011, I used to have this effect, and I used to still play the game. So I usually just thought it's part of the fatigue of playing hockey. And it persisted. I went to the hospital. I did physiotherapy. I did a lot of other things, but that is in my local village in Western Kenya. And it did not occur to any doctor at that particular moment or time that it could be something more than that. So I could do physiotherapy, I could do all those sorts of treatment except anything to do with cancer or CML. So for me, that continued until I came to Nairobi when I joined campus in 2012. I still had the problems until one night it was too much, and I was taken to Nairobi West Hospital, where I was admitted. It is at that particular point that it was discovered that my white blood count was really high, around almost 300 plus. And it's supposed to be around 5 to 11, as most of us know, between 5 to 11. So for me, there is when I was referred to.
Praise and worship.
Sorry about that. For me, there is when I was transferred to Kenyatta, and I met our able doctor, Professor Mwanda, who then diagnosed me with CML. And how do I relate my story up to this point with access? Back in the village, I could not access this treatment, this kind of treatment that I got the opportunity to access in Kenyatta. And that goes for many people in the country as we try to see how we can reach them. Many people who are not in Nairobi, who are not in the big towns, might suffer the same fate as me, as I did. And this is what I think we are trying to do, both as cancer well-wishers, cancer, the entire community that is concerned about cancer. It is something that we are trying to really work on, and to make sure that we impact people in the community. We reach every corner of this country to make sure that they get access one of the things you can relate to my story, and most people here, I think they do relate, is at the village level, we do not have this access. And for me, I came to Nairobi. When I came to Nairobi is when I was diagnosed, and I don't know what might have happened if I didn't come to Nairobi. I don't want to think about that. But what I know is, since then, 9 years later, there are so many positive impacts we've had in regard to access, in regard to general sensitization of cancer, and especially CML. We, as HENZO, the body that is known for CML, with the patients and everybody, we are trying to really make sure that people get access across the country. And this has happened together with the other stakeholders, like the Nairobi Hospital, like the Ministry of Health, like hospitals across the 4 pilot clinics that we've done across, we are doing outside Nairobi. When I joined treatment, the treatment center was Nairobi Hospital back in 2013. But now we have 4 centers which have been opened, and people can access at least treatment for CML from many other regions in the country. We have one in Mombasa, we have one in Nakuru, we have one in Eldoret, and we have one in Kisumu. So for me, there is a positive impact. There is a positive impact of access programs in Kenya, especially for people with CML. There is some growth, there is something we are doing as cancer survivors, as cancer caregivers, as cancer bodies in Kenya, to make sure that people gain access. And with that, I think we will save so many lives. We'll have very many early diagnoses, and the most important, we will not lose any lives. So I'd like to maybe just contribute a little bit to that theme, that there is something to celebrate. There is something that we as cancer survivors, we as the population in Kenya, those who are affected, are infected and affected by CML, I think we are celebrating this year for the kind of progress that we've made as an organization, as a country, in treatment of CML. Personally, 9 years along, and I'm almost, I think, even stronger than I started. I'm pursuing my dreams, and I'm living a normal life. So for me, that is something also I'm celebrating tonight, today with you guys, that 9 years ago, I was a small boy joining campus, who thought I had lost everything. My dreams were fading, but right now I'm living my dreams due to this access that we have at Nairobi Hospital and the 4 hospitals across the 4 counties. So there's something to celebrate, and let us take this day, let us make sure that we stay impactful, we stay positive, and we stay hopeful as always. Thank you, everybody who has joined. Thank you, Elo, for this opportunity. Thank you.
Thank you, Livingston. Every time I hear your story, it feels like I'm hearing it for the first time. It's such a story that it's a very good story to hear, and it's true to a whole 1,600 other people who are being treated for CML, mostly in Nairobi Hospital. That's where the program started some close to 20 years ago. And in other centers, Livingston has mentioned some other 4 centers where treatment is happening. In Kisumu's Jaramogi Oginga Odinga Teaching and Referral Hospital, in Nakuru's PGH Level 5 Hospital, in Eldoret's Moi Teaching and Referral Hospital, and in PGH in Coast, in Mombasa. But as Livingston has said, this program started in Nairobi Hospital around 2003, and Margaret Sirango has not been there since 2003, but has been there for most of that time, and she has treated Livingstone and many other people. And a lot of people here will recognize her. And I would like to invite her to briefly take us through what is leukemia, some basic signs and symptoms, how you can know that you have leukemia, and where do you go to get help when you have such a sign and symptom. So Margaret is a senior nurse at Nairobi Hospital in oncology department. You're welcome. Please take it away.
Thank you so much. Hello, good evening, everyone. My name is Margaret Sirengo. I'm a senior nurse at Nairobi Hospital. I'm very delighted to have you this evening to share this journey together. I have a small presentation, and it's actually just to let the patients and everyone know how this disease came about and how to manage and live a normal life. I'm very happy that Livingstone has actually shared and living a normal life, and we're actually very happy. Yes. I'll share my screen shortly. Thank you again, everyone. Hope you can hear me nicely. So you can hear me. Hello. So my objectives
yes,
are
I can hear you very clearly.
Introduction, definition of CML, risk factors, signs and symptoms, management. Then I'll dwell so much on infection prevention. So introduction, this CML is a cancer of the white blood cells characterized by increased and unregulated growth of myeloid cells in the bone marrow and the accumulation of the cells in the blood. It's a clonal bone marrow stem cell disorder in which a proliferation of mature granulites, that's a lot of language, and the precursors is found. It is a type of proliferative neoplasm associated with a characteristic chromosomal translocation called the Philadelphia chromosomes. That one, somebody else will go through it. That's why we celebrate on the 22nd of September, 22/9. Those are the chromosomes. Somebody else will tackle that. It's largely treated with targeted drugs called tyrosine kinase inhibitors. And the drugs have actually revolutionized treatment of this disease and allow most patients, just the way Livingstone has said, to have a quality life when compared to the former chemotherapy drugs. Previous cancer treatments, these are now the risk factors. The risk factors, one is previous cancer treatment, who have had certain types of chemotherapy and radiation therapy for other cancers, have an increased risk of developing certain types of leukemia. Another risk factor is genetic disorders. Exposure to certain chemicals can also lead to CML. We also have smoking as a risk factor, and there must be some family history of leukemia in the family. Then when we go to signs and symptoms, we always say CML often doesn't cause signs and symptoms. People are just normal until maybe when they go for a blood test, then it might be detected during a blood test. So the other signs and symptoms may include bone pain, easy bleeding with a bruise or cut, you bleed profusely, and some people even they do nose bleeding. Feeling full after eating a small amount of food, and sometimes anemia. They actually feel run down or tired. Is fever, is weight loss, loss of appetite, pain or fullness below the ribs on the left side, and excessive sweating during sleep, what we call night sweats. Then for the management, most of this, the symptoms, most of the managements actually we manage the symptoms in CML. So when these symptoms or signs are actually worrying you, make an appointment with your doctor so that you can be taken care of. There's susceptibility to infection due to inadequate primary defenses. You realize that maybe the WBCs are so high or some neutrophils are so low. So you are not supposed to come in contact with people suffering from respiratory or infectious diseases. So sometimes we really actually have to monitor the blood works regularly, like those coming for treatment, they're given forms to do some blood works before they come. So hand washing protocol, this is key and should be followed for the patients and visitors. Fever, temperature should be monitored and notify the doctor. If you have a high fever, you have to notify your doctor. Sometimes you can do something we call tepid sponging baths. There's also a risk of fluid volume secondary to increased fluid intake. This can be due to the nausea and anorexia. So we always encourage the patient to take at least 3 liters per day. Then we avoid injury or bleeding. There's way to be monitored, nutrition to be promoted. So that's why we also, when they come to Nairobi Hospital, we always ask nutritionists to advise. So we do blood pressure, heart rate. We monitor the patients when they come for treatment. Then there's this, when you're in pain, there's pain management. Most of the time, they're painkillers. So for vital signs, we also have non-verbal signs of stress in the muscles and restlessness. So we always encourage a quiet atmosphere and stressful impulses to be reduced or avoided. Noise restriction is also some part of management. So you don't go where there's a lot of noise unless it's a must, you have to go there. So for joint pains, we always allow patients to use pillows and also to be seated in the most comfortable position. Then there's periodic reposition and support with gentle exercises. That's why we always encourage physiotherapy. And when patients come to Nairobi Hospital, we always include a physiotherapist to talk to them to do those minor exercises at home. So when the anemia is too much, sometimes we always encourage blood boosters or blood transfusion can be. So we also, I said we'll dwell on infection prevention. That is hand hygiene. We'll also dwell on use of personal protective equipment, especially the masks. And then I'll also talk about respiratory hygiene, that's cough etiquette and sharp safety at home, especially sometimes when you are given some immune boosters, form of injectables, and then also safe medication practices. Then we also encourage clean environmental services every time your house is clean and just some prevention of infection. Then, so for hand hygiene, I've done it in tutorial, is a major component of infection prevention and one of the most effective methods to prevent transmission of pathogens. So it involves both hand washing and sanitizing, as you can see on the pictures. So hand hygiene, yes, you're supposed to wash hands 40 to 60 seconds. Wet hands, apply soap, rub all surfaces, rinse hands and dry thoroughly with a single use towel. Use towel to turn off the tap. So hand rubbing, we always say you do 20 to 30 seconds. You apply enough product to cover all areas of the hands. You rub hands until they are dry. So these are just the steps of hand washing. I just thought I would share with you. You wet hands the way I said. Apply soap, rub palms to palms, back hands with fingers interlaced. Then you rub palms together with fingers interlaced. Rub with back of fingers to opposing palms. Rub each thumb clapped in opposite hands. Then you rub the tips of fingers. Rub each wrist with different hands. Rinse with water. Dry thoroughly your hands. And now your hands are now clean. What is new in hand hygiene? Sometimes we like looking nice, the way you can see on the pictures, ladies. Artificial nails and cheap nail polish pose an infection risk since they result in increased hand contamination. You can apply your Accutex, but make sure it's not clipped or chipped. Keep the rings to the minimum and then keep nails neatly clipped. And also you wash your hands. So you wash your hands at all times and when the hands are visibly dirty. I'll go on cough etiquette. You cover your cough and sneeze. Then you turn away from those who are coughing. Don't cough like in the picture here, that is wrong. So persons with respiratory symptoms shall apply source control measures. You cover the nose and mouth when coughing, or you sneeze with tissue or mask. Dispose of used tissue and masks and perform hand hygiene after contact with respiratory secretions. These are the tutorial. This is wrong. You don't just cough in front of people. You don't cough in your hands, but you can use a serviette or a paper towel. You can also cough on your sleeve, or you can cough inside the collar of your shirt. This is the best practice. So we also got waste disposal when it comes to hand hygiene, especially for our patients, to ensure you have a safe waste management system. Then, immediately you dispose of waste at the point of generation, then remember to wash hands. So living with chronic myeloid leukemia requires that you connect with others like you do, like we do here when you come for treatment at the Nairobi Hospital. Then you can also join a support group. There are several support groups, and thanks to Henzo. Henzo, you are doing a good job for our patients, and may God bless you. That's the end of my presentation. Thank you. So I'll invite questions. If you have any questions, kindly. Back to you, Elo.
Thank you for the good presentation.
Yes.
Thank you very much, Margaret, for that very good presentation and the additional part on hand hygiene. If you have any question, I'm sure some of us will have it. Please let us. So we can identify. Sorry. Sorry, I lost connection there briefly. I was using another gadget. I'm back now. Thank you very much. So before I invite Dr. Mbuve to teach us a bit about treatment, is there any burning question, or can we wait until we are done with the final presentation, then we can have the questions? Just unmute yourself and ask. Someone has sent me a direct question, but I'll keep it until the end. I'll ask it at the end. So with that being the case, then I would like to invite Dr. Dennis Mbuve, who is the oncology pharmacist at the Nairobi Hospital, to take us through treatment, adherence, and what are some of the side effects that one might experience when they have CML. Dr. Dennis, if you're ready, please take it away.
Thank you, Mr. Mapelu, and good evening. Can you hear me?
Yes, we can hear you.
Thank you very much. Thank you, everyone, for this opportunity. I'm delighted to join you in, celebrating this day. This is a big day in the CML calendar. It's one of those days that we come together to discuss, to spread awareness about CML, to celebrate our survivors, to encourage those who are currently undergoing treatment, to just spread the word that CML is here with us and we do have the treatment options to tackle it. So thank you very much for inviting me. If you don't mind, I'll share my screen now. Thank you. So today we are going to just look at an overview of CML treatment and where we are with developments in this sector. My name is Dennis Mbuve. I'm a pharmacist here at Nairobi Hospital Cancer Treatment Center. As we all know, we are the site for currently the major site. We have decentralized to other sites, but we are still the major site for currently running the clinics for the chronic myeloid leukemia. So today is 22nd of September, which is the World CML Day. As Mapelu intimated before, this is the reason why we celebrate on the 22nd of September is because of the origin of CML and the whole disease progress that leads to the CML is because of the two chromosomes 22 and 9. That's why we chose the 22nd of September to be our World CML Day. The theme for this year is United in Community and Purpose Towards a Cure for CML. This is an ongoing process. It's an ongoing thing, deliberation by the medical community and everyone who is involved in management of leukemia. This is where we want to go. Today we'll be looking at definitions. We will look at a bit about the pathophysiology of chronic myeloid leukemia. We're looking at history and just a bit of understanding of where we are with CML as a disease. We look at treatment, including the history and where we are and what we need to do
Daktari, just hold on a minute. Hold on a minute. Ladies and gentlemen, please, if you're not speaking, mute. Angela Wanjala, please mute so that we can be able to hear what Daktari is saying.
Okay, thank you, Angela. So what is CML? I think as Sister Serengo has shared before me, this is it's a form of cancer, yes, and it's specifically a leukemia. As we all know, blood cancers or hematology, the cancers of the blood, they're roughly divided into two. We have the lymphomas and the leukemias. The leukemias can be said to be of two major groups. We have the acute leukemias and the chronic leukemias. Although amongst each there is a lot of variation and the disease processes are quite different. So chronic myeloid leukemia is a specific type of cancer that starts from the cells in the bone marrow that make up most of the white blood cells, the red blood cells, and the platelets. These are the cells that undergo a certain mutation. And this mutation is what gives us the very first CML cell that proliferates and creates more CML cells, and eventually we end up with the chronic myeloid leukemia. The reason why it's termed chronic is because it progresses over a long time, usually sometimes without any signs or symptoms, and sometimes its signs and symptoms mimic other diseases. So it goes a bit of time before somebody is eventually diagnosed with the disease. So genetic changes in early cells in the bone marrow or lead to the creation of a CML cell, which later now proliferates and creates the disease burden that we now clinically treat as CML. So the two chromosomes that we talked about that are involved, as we all know, chromosomes are carriers of DNA in our cells. Each cell contains nucleus, which contains chromosomes. During cell division, and there's mixing of chromosomes, if you just put it in simple terms, and sometimes these mutations, which can be of many types, can lead to unstable cells. These unstable cells are cleared out by the immune system of the body, because they are able to be recognized and cleared from creating more problems. However, there are some cells, there are some mutations that survive and can lead to cancer. One such mutation is called, it's a translocation mutation between chromosome 9 and chromosome 22 of the cell. This chromosome mix up, and the gene, every chromosome is made up of, every DNA strand is made up of several genes. Every chromosome, sorry, is made up of several genes. So on the chromosome 9, we have the ABL gene, and on chromosome 22, we have a BCR gene. These genes, once these chromosomes mix up and they create a new chromosome, which is now termed the Philadelphia chromosome, they form a new gene called the BCR-ABL or BCR-ABL, the gene. This gene codes for a certain protein on the cell surface of the cells, of the myeloid cells, that is a signaling cell, a signaling protein. This protein directs those cells to produce more cells or to grow faster and divide faster. And now that's what causes all these problems. So one big problem with this gene, that is the new gene that is created by this mutation, is that this BCR-ABL protein called a tyrosine kinase protein is constitutively activated, meaning this it's always active. So when signaling in the cell or communication in the cell for growth, differentiation, proliferation is usually a switch. You switch on, you switch off when the cell is supposed to divide, and when cells are supposed to be dormant. But this BCR-ABL gene directs these cells to divide continuously, even without other signals telling it to either stop or continue. So that is the biggest problem, which leads to the increase of these CML leukemic cells. And this leads to the disease that we now see clinically. The reason why the disease comes out is because these leukemic cells are, they crowd out other normal cells in the bone marrow, and they also spill out in the blood. So that crowding out of the normal cells is what leads to anemia, leads to thrombocytopenia, and somebody's susceptible to bleeding and infections, and they feel weak because of all the things, all the failure to carry out normal physiologic processes. So we'll look at the symptoms of CML. As sisters mentioned, because of now these cells that are crowding out the normal cells in the bone marrow, you have increased risk of infections because of the platelets being low. You have risk of risk of bleeding because of low platelets. You have risk of infections due to low and white blood cells. Although a lot of white blood cells are mature in the blood, the leukemic white blood cells, which are now dividing and proliferating, in later stages, these cells continue to be less and less mature, and they lead to problems because the less mature cells are not able to carry out the full functions of mature cells. So this is what causes problems. When these cells are crowd out, they get into other tissues. We have issues there. We have enlarged spleen because of increased clearance of the white blood cells and the red blood cells. You have increased, you can have tumors growing elsewhere in the body, which we call now the myeloid sarcomas, although rare with CML, but sometimes you do get such disease processes. CML has been known to be a disease since the late 1900s, mid to late 1900s, and 19th century, sorry. We've known that leukemia leads to proliferation of cells in the bone marrow since the 1950s. In 1960, scientists were able to identify the Philadelphia chromosome, which is formed by this particular mutation. And this has led to quick gains in trying to find out the management for this disease. So in 1973, where we realized that this Philadelphia chromosome was formed by this translocation mutation between chromosome 9 and 22. Later on, the BCR-ABL fusion gene was identified. This is the new gene that is formed by the translocation of these two chromosomes. Then 1990, we were able to replicate this disease process by causing this mutation to occur in mice, and that led to a CML-like disease. And then we were able to, identify this BCR-ABL forming mutation as the, the major pathophysiologic process that leads to CML. In 1996, in the 90s, the scientists now, because now we know that this is the major problem in CML, then we went ahead and looked at how we can block that kind of activity that is creating these abnormal cells in the bone marrow. Now, blockade of the BCR-ABL kinase activity was demonstrated well in 1998, and in 2001, the first selective drug that works against this mutation, this protein formed from the mutation, was granted FDA approval in the United States. So that is a brief history of CML. Now, the CML treatment also follows the same, because with every disease, there are treatments that come about. Late 19th century, we had treatments such as arsenic, which were very toxic, but at the moment they were the best solution for the problem. There was irradiation, X-ray radiation, and chemotherapy was introduced in 1940s. With the nitrogen mustard being the first agent that was utilized. Busulfan and hydroxyurea antimetabolites were used extensively in 1960s, 1970s. Thereafter, transplant technology was tried in CML with allogenic grafts being used in from first, siblings, and then later with unrelated donors. So transplantation, bone marrow stem cell transplants, basically taking healthy stem cells from healthy individuals, and after you have cleared off all the cells in the bone marrow, you restart. It's more like restarting the bone marrow using the stem cells from a donor. So that was used. Interferon alpha has been a key treatment in CML, offering good treatment. However, there are challenges with that. 1984 so-called prognostic scoring system was developed. This was just to look at the survival rates of the CML patients. And later on, in 1990, we started using lymphocytic infusions, especially to treat patients who are relapsing from the transplants. First clinical use of the targeted therapy was in 1998. Although the FDA and the other regulatory authorities later gave it accelerated approvals later in the early 2000s. Sorry. So that is the history of treatment of CML. So we've come very far. We've come from very toxic treatments, from arsenic to chemotherapy, and now to targeted therapy. Targeted therapy basically means we don't go in blind. We go in targeting specific proteins or specific enzymes or specific targets in the cell, so that we are able to reduce the risk of affecting normal tissues or normal cells. So the rise of targeted therapy started with understanding the molecular basis of the disease, such as we've seen. Then we started now rationally producing these specific small inhibitory molecules. And the very first molecule that we produced for the treatment of CML was imatinib. As we all know, Glivec has been with us since the inception of the program. And basically, GPAP is, as the program was previously called, was based on the provision of free imatinib to CML patients, so that they're able to access this life-saving medication. So prognostic or survival rates for patients when they're under treatment for other treatments such as chemotherapy were not very good. CML was a killer disease back then. And what we've seen since the inception of targeted therapy is a dramatic change in all this. Matter of fact, CML or chronic myeloid leukemia is the first cancer to have normal survival, or rather patients living normal lives, going about their businesses, even many years after diagnosis. So it's a very, very, very big step in the treatment and the management of leukemia. Previously, stem cell transplants were the only way of treating, or definitely treating CML, but now with targeted therapy, we are able to manage patients long-term on oral therapy that can be taken at home as the patient continues with their normal lives. So we have several BCR-ABL tyrosine kinase inhibitors, or TKIs. These drugs include imatinib, dasatinib, nilotinib, bosutinib, ponatinib, and others which are in development. All these are available currently. Most of them are available under the program for first line or second line or third line treatment of CML. So when we talk about imatinib, we are talking about a TKI, or tyrosine kinase inhibitors. It works by basically blocking the BCR-ABL tyrosine kinase, as we have seen before. And this medication is given orally. It's well absorbed when it's given by mouth. It's metabolized by the liver, and it's eliminated by the kidneys. Nilotinib is another medication that we've seen being used in this clinic. It came in as a second-line treatment for patients who have relapsed or who are not able to tolerate imatinib. And this, but later it was given approval for first-line treatment. So it works the same as imatinib, although it has a more potent binding to the BCR-ABL kinase. It binds to the same, to the different, but the same binding site as imatinib, the ATP binding site. It's taken orally, also eliminated through the liver and the kidneys. Imatinib for chronic myeloid leukemia is started at a dose of 400 milligrams taken once a day. Now, what we mean by chronic phase of CML is that most patients who are diagnosed with CML are diagnosed during the chronic phase. Unlike normally you'd think of the process coming from an acute, then chronic, and all that. In CML, we start with the chronic phase. Thereafter, we have an accelerated phase, and lastly, we have the blast crisis or blast phase, which is the more severe disease. So with the chronic phase is usually the first phase, and this is the first line treatment for first line for chronic phase, chronic myeloid leukemia. So imatinib at a dose of 400 milligrams taken once a day is usually sufficient to induce remission of the CML disease. The chronic phase after failure of interferon alpha, we start at a higher dose. And after disease progression, we might switch, or we can increase the dose to around 800 milligrams, divided into 400 milligrams twice a day, in absence of any severe adverse reactions. For newly diagnosed patients who are treated with nilotinib, we start at 300 milligrams once a day, also taken orally. So the tablets, the capsules, in other words, resistance to first-line treatment, that is people who have been on imatinib, then we start at 400 milligrams twice a day. So two capsules of 200 milligrams taken twice daily. The key thing to note with the difference between nilotinib and imatinib is that imatinib is well tolerated when taken after a meal, while nilotinib, taking nilotinib with food might increase the incidence of side effects. So nilotinib is taken at least an hour before meals, or if you've eaten, you take it at least 2 hours after that, so that we reduce the fluctuating blood levels due to the food effects. The side effects of this medication, imatinib is a well-tolerated medication, as most of the patients who are listening to this webinar will attest to. However, we do have a few side effects that we might encounter clinically. The major side effects are hematological adverse effects. It may lead to anemia, thrombocytopenia, neutropenia, that is independent of the disease itself. We might experience, so anemia is basically, reduced hemoglobin because of reduced red blood cells counts. Thrombocytopenia is reduced platelets, and we might this might predispose the patient to bleeding issues. Neutropenia, reduced neutrophil count, might lead to opportunistic infections, such as upper respiratory tract infections and all that. Fluid retention and edema, peripheral, limbs and all that. That can be an issue with imatinib and related molecules. GIT side effects are common, especially with first-time patients, but these ones can be managed well if you take it with a meal. Musculoskeletal pain might be a problem, and this can be managed easily with analgesics. Hepatotoxicity is also a concern. Hematological adverse effects, as shown here, are anemia, neutropenia, thrombocytopenia, managed as seen below, seen here. Anemia can be managed using recombinant erythropoietin. Neutropenia can be managed using recombinant granulocyte colony stimulating factors such as filgrastim. Thrombocytopenia might be managed using drugs that such as the entropopag. You might use platelets infusions. Edema, you do supportive care. You also give diuretics if needed. Fluid retention, you may restrict salt. You might add diuretics, or you might use other supportive care options that you have. GI irritation may be reduced by taking imatinib with a meal or that tall glass of water, or taking it in the evening so that you can sleep off most of the side effects, but not just before bed, to reduce issues with reflux. Antiemetics might help, also supportive care. The cramps may be managed, or the bone pain and arthralgia may be managed using increasing fluid intake, balancing calcium and potassium levels, tonic water, and painkillers. So what does this mean for the CML patient? So the patient, the role of the CML patient is to first adhere to the prescribed medication. So the patient is able, you're supposed to make sure that you adhere into the medication that has been prescribed to you and any other treatment that has been given to you. to honor clinic appointments so that you are able to monitor your progress and also to manage any side effects or other issues that you might have. You're supposed to inform your doctor of any herbal medication or any supplements that you're taking. Store your medication very well. You're also supposed to make sure that you support others and join a support group or Henzo or any other group that is available to you so that we can also encourage others. The things that you're supposed to avoid is other medication unless prescribed by your doctor. So you should avoid any, taking medication without thinking about how those medication might interact with your, imatinib or your dasatinib or the rest. Do not use medication past expiry date. This has been an issue before, but I'm sure now we've learned and we are not keeping medication until expiry. So you use what you've been given during the clinic, and that's once that is done, then you can use any other batch that is given to you. You're supposed to avoid herbal medications or any other alternative medication unless you've discussed this with your doctor and you've agreed, because some of these herbal medication, even though we agree that alternative medicine has a place in management of a lot of diseases, they might interact with your drug, either make it more, may give you more problems with side effects or might reduce the effectiveness of efficacy of your treatment. Do not share medication with other patients. Do not sambaza medication. Do not try as much as possible to get your own supply, because that shows that you're committed to this treatment and you're able to be seen. So if you miss a clinic, get in touch with the clinic, get in touch with Henzo so that we can see how to help you. So do not store medications, and in anticipation of shortage, we have had this problem before. But right now, I know we've learned and we are not storing medication, thinking that maybe out of stock situation will come about in the future. So this is just a pictorial to show that these two are different, but they also work the same way. How do I take my Gleevec? So Gleevec is taken with a meal or a large glass of water or juice. You can take it with apple juice or any other juice that is available to you. However, there's just a few things you may want to avoid, such as grapefruit juice, but I believe that is not common in our setup. If you're not able to swallow, then you may disperse these tablets, because most patients are on 4 tablets. You may want to disperse these tablets in a glass of water or juice. So you just remove your tablets from their film, you place them in your glass of water, and then wait out for them to disperse. Do not crush, do not chew. You disperse them and you take them as the granules. After that, you will just swallow. You just add in a little bit of water and clear out any remaining sediment or suspension at the bottom of the glass, so that you get the entire dose. Do not chew. I repeat, do not chew or crush the tablets, because this may lead to irritation of the mucol, the mouth cavity or the skin. What do I do when I miss a dose of my medication? This question has been asked frequently. So if you've missed your medication and it is within 12 hours of the last dose that you took, you may take a dose with a meal or a large glass of water. If the dose that you've missed, you've remember that you've missed a dose, but it's almost the time of taking your next dose, so it's more than 12 hours since you missed a dose, then you will not take a double dose. You will wait out and take your dose, your next dose at the right time. So let's say if you're taking your Gleevec at 7 p.m. and you remember the next morning at around maybe 4 a.m., you may take your Gleevec as prescribed and then take your next normal dose. If you remember past 7 a.m., then you will wait out for the next dose and take it as normal. Do not take 2 doses to make up for the dose that you've missed. Take your normal dose, but you may document that and discuss that with the doctor on your next visit. How do we handle Glivec? Glivec, as such as any other medication, is supposed to be stored at room at a cool, dry place, away from children. Do not expose the tablets to light. Do not crush the tablets. I repeat, do not use broken tablets. If you have any broken tablets, kindly return them to the clinic. Avoid direct contact or exposure to crushed tablets with the skin or the mouth or any other mucous membrane. Is if you happen to touch or come in contact with broken tablets, you can wash off with clean water, soap and water. If you get any tablets or powder in your eyes, wash out until no irritation is felt, and then you may want to seek medical attention. Where should I avoid when taking my CML medication? This medication may cause issues with your faculties in terms of vision. So if especially new patients who are not gotten used to their medication, if you encounter any dizziness or drowsiness, do not drive, do not operate machinery, sorry. Do not take grapefruit juice with the imatinib, as I've mentioned. Avoid being near people who are sick or have infections, because you're more susceptible to getting infections yourself. Avoid activities that may increase your risk of bleeding. So protect yourself from injury, from activities that may lead to excessive bleeding. But with time, you may engage in any other activity that is good for you, as long as you've been given a clean bill of health by your doctor. As usual, avoid or stop tobacco use, and avoid excessive consumption of alcoholic drinks. What other drugs affect the way my CML medication works? This question has been asked frequently. Remember, not all medications are safe to use with your Glivec or any other medication that you're taking. Tell your doctor or come to pharmacy and mention to the pharmacist if you're on any other medications, like antibiotics, if you're on blood thinners, vitamins, or any other supplement. Over-the-counter or herbal products may also interfere, so kindly disclose that information to us. This question of pregnancy and lactation with medication, Glivec has been known from animal studies that it can affect the developing fetus. So if you're planning to get pregnant or you're already pregnant, kindly mention this to the doctor. Before we start Glivec, we're supposed to ensure that if you're of childbearing age, you're on contraceptive that has a less than 1% failure rate, and that you are adhering to the same. Imatinib and related products are also present in milk, so we advocate for avoiding breastfeeding during treatment and at least for 1 month following any discontinuation of treatment as advised by your doctor. So in conclusion, I can say that over the last now it's around 70 plus years of trying to manage CML clinically, that there's been a lot of remarkable success. When I say that success, I mean that we have more than 1,000 patients who are attending our Mark Success Solutions clinics, and we are seeing patients who have been asked for so long, and people are living their normal lives. They're taking their medication as prescribed, and for the very first time, we have a cancer that is manageable in the long term, with patients living normal lives. So this is a very, very important discovery, and it's one area that Novartis have really helped us, because they've given us this medication free of charge for the patients in the country. For all the CML patients in the country are given free Glivec for as long as they need it. And this has been a commitment that has really helped us to be here today to celebrate the World CML Day. So I would encourage any patient, any caregiver who is engaged in this program to continue giving to meeting their expectations, their roles and expectations, and helping us continue to celebrate year after year, and hopefully for a future cure for CML. So thank you very much. I will invite any questions either via chat, or if you have any question, you might unmute and ask, and we'll tackle them. So thank you very much. That was my time. Thank you.
Thank you, Dr. That is very informative. We really appreciate taking time to prepare that presentation for us. And we are very well informed now. I can see a number of questions, most of which I believe for Dr. Mbuve. But I can also see some hands up. Peter Whiter, you probably could start with your question. I can see your hand is up. Please unmute and ask your question, Peter. Perhaps as Peter is trying to get that one, Dr. There's the question that came in very early on. I think just when I was doing the introduction, someone was asking, what is the estimate cost of treating CML? That's besides the program. Do you have a response to that?
Hello. So treatment, the cost of treatment, if, and I believe this is common knowledge, if we were to, if CML currently was being treated without the help of a program, or what we call the patient support program, or an access program, a treatment would probably be not less than 300,000 per month, taking into consideration the cost of medication, the cost of doing your lab works, or attending clinics to be seen, the consultation, fees that would have to pay for. So I believe currently the cost of treatment is almost negligible compared to if we were not able to offer this kind of treatment for free. Currently, the doctors offer their consultative services and follow-up services for free. Medication is offered for free. I know we've negotiated for improved rates for the laboratory charges, for especially for the PCR tests, because the PCR test for BCR-ABL is the whole.
Did we lose Dr. Mbuve? Looks like.
Yeah, I think so, yeah.
Okay. But maybe just to add on to what he was responding, currently treatment is only available through the program that is being sponsored by Novartis and managed by Max Foundation. Buying it out there will cost at least 300,000, which is a cost for medicine alone, plus other costs, which are also been taken care of by other partners. For example, consultation, all the doctors who are in the program give their services for free. The only thing we do is that we try to make it possible for people to come on a particular day, a Saturday specifically, to get the services free of charge. Otherwise, if you will go to see the doctors in their offices, you'll be required to pay the administrative costs for that. And going forward, we're also trying to work closely with NHIF to make sure that other second-line treatments that are not available through the program are available through the NHIF, and we've been working closely with NHIF towards making sure that that is realized. And Novartis has also been key in helping us be able to achieve that. And still also on NHIF, we're trying to see how they can be able to cover the costs of diagnostics, especially the PCR tests, which is fairly expensive. They're trying to see how that one can be put into the program, the NHIF program, so that people can be able to access that using their card. There's another question here: is CML hereditary? That is from parent to child. As much as I know, it is not. I'm sure immediately the Tari comes back, he'll give us further information on that. There are other questions here. From Victor Boyd is asking, at this time, do we have treatment for this CML apart from Glivec drugs? If so, when is it necessary for the same? This one, I want to allow Margaret to...
Hello, sorry, I'm joining through Margaret's connection. I just lost my connection.
Oh, sorry.
I hope you'll allow me.
No
I think we are in the middle of answering the first question.
Yes.
About the cost of treatment. I was just saying that we currently the cost of treatment is almost negligible compared to the commercial cost of treatment if we didn't have the program. So the patients nowadays are since the inception of the program, we've only asked for a bit of for the lab test and any other treatment outside of the Glivec and related drugs which are in the program. Currently, nilotinib is not covered under the program, and if you move to the other second line, the treatment or under nilotinib, you might have to look through ways of managing the cost of that. However, NHIF is a very big partner in cancer treatment in the country, and they do pay most of it, if not entirely, the monthly cost of nilotinib. So, looking at all that, it's very important that we remember the gains and we look through how we can help each other better. But I could say that we have not, we've made a significant gain so far in terms of treatment. Let me just look through if you have any question. Or Mapel, you have a question for me?
Just a quick one. Although this one in your presentation you dealt with it. Someone asking if there's any other treatment apart from Glivec. You mentioned about the different types of treatment, so that I covered. There was that one on hereditary. Is CML hereditary? Probably could deal with that.
Okay. And, now about other alternative treatments. As I said, we used to look to the transplants being our only options in terms of eventually dealing with CML, if not chemotherapy that we used to, the toxic chemotherapy that sometimes patients were not able to either complete treatment or they would develop other issues. So currently with targeted therapy, we are able to live normal lives and manage this disease without an issue. So the need for transplants has really gone down, although there are still patients who will require that and patients who would require other treatments outside of the targeted therapy. So I would say that there are other treatments, but most patients would first go through targeted therapy as a first-line treatment if they are if they have this BCR-ABL mutation, of which 95% of all diagnosed patients with CML have this mutation, and the fusion protein can be detected. So I would say that's that. The question on hereditary nature of CML. No, currently we believe CML is not although it's a genetic, the fact that it's a genetic disease, as most of the cancer, right? Not all the cancer. It comes from a genetic issue. issues with the genes, but those issues are not passed down to the progeny or the offspring, because they mostly happen in the what we call somatic cells, or the cells that are not involved in formation of offspring, or for the gametes which are involved in that. So it's not passed down as a disease, passed down generations. However, some of the risk factors may be affecting a family. So if you have a high, a very rich history of cancer in the family, the risk factors might be there, but doesn't mean the disease is given from mother to child or father to child. So that is that. So it's not hereditary in that nature, but the risk factors might affect people of the same family, but not the disease itself being passed down from mother to child or father to child. Yes. Any other question, Michael?
Yes, there is a question on. I'm trying to scroll. Oh, this disappeared. Oh yeah, it's here. So if you have an aching tooth, is it advisable for patients using the drug to have the teeth removed?
So tooth extraction, before you undergo such a procedure, which might have two risks associated with it. One risk is the risk of bleeding, and the other risk is the risk of infections. So if you are having any other an issue such as a tooth that needs to be extracted, your doctor will need to advise you on when you can have that done. Because if you have very clinically your blood levels show that you have diminished ability to clot, or you have issues with the neutrophils and all that, then may have to wait for those to be boosted a bit for you to be able to undergo such a procedure. And this goes for surgery and any other treatment, major treatment that you might be advised to go for, maybe by another doctor. You need to, we need to discuss this so that we are able to make sure that you don't come out of it worse than you went in. Yes. So I have seen another question here by Grace. Your question is if there's a young family who may need to add another baby, I presume, or rather those without kids, at what stage of medication are they allowed to conceive? So conceiving on treatment is one of the issues that, of course, it's an emerging issue. We understand the need, the need for families to grow, the need that mothers and fathers may have, and it's important that we discuss this issue. It's been known that people with CML or people who are suffering from CML, you may conceive normally without any other issue. However, if you're under treatment and Gleevec, as we've seen, is been shown not to be safe for expectant mothers, then this is a discussion we have with the doctor. You present your doctor, you say, of course, I'm intending to 1, 2, 3, and we need to first make sure that you have a very high molecular response to the medication, so that we know that if we interrupt this treatment for a certain period of time, that by the time you conceive, you're not worse off in terms of the clinic, in terms of the disease. So there is a way that we can suppress the disease to the level that we can stop for a while, that you conceive and come back to treatment. But those are discussions that we need to discuss and agree with the doctor based on your clinical situation, so that we are able to tell you Because if your disease is in the accelerated phase, or you're failing on treatment, or you've gone into the blast crisis, then if we interrupting or stopping treatment at that time, the outcome might not be very good. So we need to discuss so that if you're in remission and if your molecular response is excellent, then we can discuss on how to interrupt and restart. That is a discussion that we make at the clinic. Yes, I can see another question here. Can premature or instant vegetation be a side effect of Gleevec? And this will be taken care of. Now, remember, this is not a major side effect of Gleevec. However, some patients have experienced such issues, including issues with being able to either sustain or what we call impotence. Huh? So either premature ejaculation or impotence can be as a result of Gleevec or any other issues, including the disease process. So this can be managed, can be advised, can have counseling sessions. We can tell you how to manage it either clinically or with supportive care. But at the end of the day, if such is a problem, kindly share. We usually have counselors. Sister Sirengo is a counselor. She can also help you with some of these issues. And if need be, the doctor will advise on the treatment that we can give you to manage any or such side effects that may arise. Is it risky to use hormonal family? This is a question by Winnie. Is it safe to go for tubal ligation while on treatment? Hormonal family planning has its own risks which are outside any interaction with treatment for CML. So you will discuss that, of course, with your fertility doctor, with your doctor, or with the person who is initiating this treatment for you. That hormonal family planning has its own risk factors outside of what treatment you'll be getting from the clinic. Now, interaction with hormonal interaction with Gleevec is not common unless that the particular medication that you've been given interferes with either metabolism of the Gleevec or such interaction, and that can only be made once we know exactly which hormonal family planning has been put on. So it's always good because we always review here every month or so. If you're planning to start something major like this, then of course you can share with us. You can come to pharmacy. We can talk about what is the safest hormonal family planning treatment, or generally what is the safest family planning method for you. Tubal ligation being usually a semi-permanent or permanent in what's treatment contraceptive method it's a surgical procedure, although not as major as such other procedures. We may want to again discuss with the doctor. It can be done. It is one of the contraceptive methods that will really help us to maintain you on this targeted therapy without risk of harming a developing fetus. So it can be done, and it can be done safely, but you will need to discuss with the doctor so that we give you the clean bill of health for you to be able to go ahead and do the procedure for contraception. Any other question?
I think, Dr. we've dealt with all the questions. There's a comment here that Grace, not Grace, it's Lillian Gira is saying, thanks for hosting the program. I have never known that people can be healed from cancer. The story of Livingstone is encouraging and eye-opener. I think it's a nice high to live, to end the meeting at. So thank you so much, Dr. for availing your time for this. Sister Sirengo, we really appreciate your time as well. and Livingstone also for sharing your story and being an encouragement to so many people. But before we even end, I want to say thank you also to everybody who has made this possible. Glivec, as you know, is donated by Novartis. They've worked with us closely for over these many years. And I can see Magdalene Nduli is here. I just want to give a few minutes to say hi, just to share with us this warmth of CML Day. Magdalene?
Thank you so much, Mapelu. I hope you can all hear me loud and clear.
Yes, you can.
Great. Thank you so much. I must say that it is a great honor to join such a great meeting, such a great webinar. Thank you to the speakers of the day. I did rather join in a bit late. Kindly have my apologies for that. But I really did enjoy the bit that Daktari took us through, teaching us, letting us learn so much about CML, and that indeed with the right care, the right quality of management, that the patients will be able to lead normal lives. So I would like to appreciate the speakers for the day. I think you've all heard my name is Dr. Magdalene Nduli, and I'm from Novartis East Africa cluster. I work as the medical advisor within the oncology franchise, where CML or chronic myeloid leukemia is domiciled. As I said, I appreciate the speakers of the day, the time that they have taken to educate, to encourage, and to just provide support for all the patients in this fora. I would say a very, very huge kudos to that. I think we have all seen more so through Daktari's presentation that with the right form of management, patients who've been diagnosed with chronic myeloid leukemia can actually lead very normal lives and have fruitful, good quality, not just live, but have good quality lives. Indeed, Novartis came together with Max Foundation to lead to the creation of the GPAP program, which is currently now being called the CML Path to Care program. Through this program, we've all had through Daktari and Mapelu that patients were then able to get provision and get Glivec or imatinib free of charge. And other than that, Novartis has also supported, in essence, and availed a second line molecule called nilotinib or Tasigna, which is currently reimbursable under NHIF. So really, mine is to just thank you all for bringing this meeting and for having this forum where patients can learn, where we can all see the efforts that are being put in place. Thanks to also Nairobi Hospital for providing the administrative framework to ensure that this program that has been supported at the facility for all these years since the inception in 2002, consultants giving their time. We have a number of lead physicians who see the patients every 2 weeks, dedicating their time, dedicating their efforts to ensure that patients really do get the right quality of care and the right form of management. So as I conclude, I think we are all aware that Rome was not built in one day, and that there are still some challenges that patients do face in terms of accessing the right medications. So for us as Novartis, our motto really, or our drive, is to ensure that we strive to reduce the burden of CML through research, through development, and through strengthening the health systems that are in our country. So I won't take too much time, Mapelu. Mine is to thank you all, to appreciate you, and to wish you all a great evening. Thank you, Mapelu.
Thank you, Daktari, and please pass our gratitude to the entire Novartis fraternity. Asante sana.
Indeed, I will. Thank you.
Yeah, I also want to recognize Fred Asige. He's the manager at Cancer Center, Nairobi Hospital. Fred, just a minute to greet us.
Thank you very much, Mapelu, for organizing this kind of CME. I appreciate everyone in attendance and even for the organizers, as Magdalene, Dennis, and the entire team, Margaret, have also been able to communicate to the entire, to the attendees. I think this is a milestone where we have come from and where we are heading. And the biggest beneficiary definitely is actually for the good of the patient. Us in TNH will just give the supportive advice and also care for the patients while seeking treatment here. Thank you all, and looking forward to the celebration on Saturday.
Thank you, Fred. Please pass our gratitude to the CEO, Medical Director, and the whole team at Nairobi Hospital. Through their generosity and partnership with the Novartis, we have a big celebration planned for Saturday. We'll have a whole day with Dr. Dennis, Sister Margaret, and many other doctors who are going to be with us as we celebrate the World CML Day on Saturday from 8:30 to around 3 p.m. at Nairobi Hospital Lecture Hall. So those who will not be able to come, you just got a bit of it now, but those who are able to come, please make sure you come. It's going to be a great day. We're going to celebrate together, and that's thanks to our partners, Nairobi Hospital, Novartis, and others. Did I see Lucy Mwangi? I wanted to say hi, Lucy Mwangi from Max Foundation, very briefly.
Hi, everybody. Hi. I think everybody else has said most of what need to be said. I just want to appreciate everyone, our partners, the doctors, the patients, the hospital for supporting us in the work we do. Without them, this program will not be where it is. And I am happy to be here celebrating with everybody, the patients who worked patients for 18 years, and it's a joy to see them every day, that they are still fighting and they are still living their normal life. So thank you, and good evening, everyone. I hope to see you all on Saturday. Thank you.
Thank you very much, Lucy. And finally, I want to ask Charles to just greet us. Charles Muya is a programs officer from Kenco. They helped us put this webinar together. And on behalf of Kenco, Charles, just say a few words.
Thank you so much, Mapelu. And I would also want to join other speakers in appreciating our speakers for today, Dr. Dennis and Sister Margaret. I believe we've all learned one or two things, and it was quite informative. In fact, I didn't realize that we've run out of time because the presentations were quite engaging. So thank you very much to our speakers, and I would also want to thank us, the participants, for joining us today, for being active, asking questions, and I would really want to appreciate you for that. So as Mapero had mentioned earlier on, we are going to reimburse your data bundles, and that's why you are asking for your phone numbers when you are registering for the webinar. So look out for that in the coming week. And these are a series of monthly webinars that we've been running, supported by Janssen Pharmaceuticals. And next month, we are going to be focusing on nutrition in cancer care. So you can look out for the poster towards the end of the month and be able to join so that we can continue learning. In case you missed anything in the course of the webinar, maybe because of internet connection or something like that, you can check out the recording in our YouTube channel, that is Kenco Network, in the coming week. You'll be able to have that and refer. Otherwise, thank you very much for joining us, and have a good evening. I'm Charles from Kenya Network of Cancer Organizations. Thank you.
Thank you, Charles. Thank you. Thank you very much, Charles. Thank you, everybody who tuned in. Clearly, time has really run. It was even getting better and better as time went. But like everybody else has said, on Saturday, we'll have a whole day to do exactly that. And because of the generosity of our partners, we'll even have lunch to share together. We'll even have a cake to share together. And Livingstone wants to teach us a new dance style on Saturday to celebrate his 9 years of walking this journey. So thank you so much, everybody. I can see Priska from Kenco is there. Thank you, Priska, for joining in. Priska is the secretary of the board of Kenco. Thank you for joining in. And every other person I was not able to recognize, please, thank you for joining and thank you for supporting us. I want to repeat the words of Fred. Whatever activity, whatever effort you're putting here, it goes towards helping the patient, survive this diagnosis of cancer and actually getting better, enjoying a better life. So thank you so much. See you on Saturday. I want someone to close for us with a prayer. Any volunteer?